compose myself. My name is Lauren Caldwell. I'm a critical care pharmacist at the downtown campus at Erlanger Health System, and today we're going to discuss our Alteplase to Tenecteplase conversion that's going live on February 1st. In our audience, we have Dr. Cleopatra Thurman as well as Dr. Kassab, who are representing neurology. So today we're going to do a very brief overview of Tenecteplase. We're going to do a quick literature review about the evidence behind Tenecteplase use in acute ischemic stroke, review some dosing and administration instructions, and then some changes in the processes of what Tenecteplase use will look like at our outlying facilities. So Tenecteplase is an Alteplase variant, has a longer plasma half-life of 18 minutes, which allows for it to be given as a single IV bolus injection compared to TPA or Alteplase, which is a 4-minute half-life requiring a continuous infusion. Tenecteplase has no procoagulant effects, as well as an increased fibrin specificity, which allows for a reduced bleeding risk. Currently, we have multiple studies showing equivalent or improved efficacy to Alteplase with potential for reduced adverse events. So our brief literature review, we'll start with the ATTEST trial from 2015. It was a 0.25 milligram per kilogram dose that was studied, and it was found to be non-inferior to TPA with no difference in spontaneous intracranial hemorrhages. The NORTEST trial from 2017 looked at a higher dose of 0.4 milligrams per kilogram of Tenecteplase and found that it was not superior to TPA. It also found a similar safety profile. However, these patients were of a mild stroke symptoms with low NIHSS scores. The Extend-IA T&K trial from 2018 looked at a dose of 0.25 milligrams per kilogram and found that it was superior to TPA for prior to thrombectomy in patients with large vessel strokes. Part 2 of that was published in 2020 and looked at a dose comparison of 0.4 versus 0.25 milligrams per kilogram. And they found that the 0.4 dose does not actually confer any advantages over the 0.25 milligrams per kilogram. So this year, the NORTEST 2 trial came out, and it was actually stopped early due to futility from worse safety and functional outcomes at the higher dose of 0.4 milligrams per kilogram. The TASTE-A trial was also published, and they looked at a dose of 0.25 milligrams per kilogram and found that that dose resulted in a superior rate of reperfusion when compared to Alteplase. And lastly, the ACT-2 trial, which also came out this year, looked at a dose of 0.25 milligrams per kilogram, and they found that it was a reasonable alternative to TPA for patients who meet criteria for thrombolysis. So based on our primary literature evidence, our health system will move forward using Tenecteplase at a dose of 0.25 milligrams per kilogram. So when you go to order Tenecteplase for acute ischemic stroke, please utilize the order set to ensure appropriate dose as well as dose rounding. This is to potentially avoid a major medication error, as the dose for Tenecteplase in acute ischemic stroke is 1/2 of the dose of Tenecteplase that you'll see for myocardial infarction, or STEMIs, which is 0.5 milligrams per kilograms. This is an example of what our order panel will look like within Epic. It's currently being built, as I do not have an exact replica of what it will look like, but the dose will be 0.25 milligrams per kilogram. You must make sure that your nurses have flushed it pre and post administration, as Tenecteplase is not compatible with dextrose-containing solutions and will precipitate in the line. So within this order panel, we have implemented some Tenecteplase dose rounding. So when you go to order Tenecteplase within Epic, you'll have to select a dose range, which has then been rounded to a whole number for a dose, as well as the closest 0.2 ml for a syringe for ease of nursing administration. So please ensure that you have an accurate weight as well as timely charting so that your patient's thrombolytics agents are not delayed. So our outside facilities, such as Sequatchie Valley, Bledsoe, North, East, as well as Western Carolina, will all be converted to Tenecteplase starting February 1st. These facilities will also carry Tenecteplase for acute myocardial infarctions. And starting February 1st, they will have a new way to order Tenecteplase. So it will only be available through order panels, such as the acute ischemic stroke panel or the STEMI order panel. So this order panel will not be available for use at the Baroness campus due to we have 24-hour PCI capabilities. Right now, Tenecteplase is able to be ordered at outside facilities as like a free text. And so we just wanted to make sure to reduce medication errors that it was only available through an order panel. So storage for these medications, since they are the same, they will be broken down and look very different. So they'll also be both stored in the Omnicells. So prior to removal, the person who wants to go to remove it will have to select an indication prior to its removal. So they will have to select either STEMI or acute ischemic stroke. Hopefully that your patient's orders will be placed prior to removal from the Omnicells. However, if you were to override it, the indication must be selected. So the STEMI Tenecteplase will remain stored in its original packaging, which contains a vial of sterile water, the 50 milligram vial, as well as a syringe for mixing. It will have a sticker that says specifically STEMI Tenecteplase, as well as the 0.5 milligram per kilogram dose on it. However, Tenecteplase for acute ischemic stroke will then be broken down out of the box and placed into kits that we have developed for Omnicell storage as well that contain everything the nurse may need to withdraw, dilute, and administer the medication. So the Tenecteplase kits will contain the vial of Tenecteplase, one 10 ml vial of sterile water for dilution, 2 flushes for pre and post line administration, a 10 ml syringe for dilution, a 5 ml syringe for dosing, and 2 blunt tip needles. So of note, Tenecteplase should never be administered for a stroke in a syringe size larger than a 5 ml, as the maximum dose is 25 milligrams. We have also developed these dosing cards that will be placed within the kits. This just allows for easy nurse administration and instructions, as well as what their dose would look like based on your patient's weight range. So this is the same as what's built into Epic. For our post-thrombolytic care will remain the same as before. Our blood pressure goals will remain the same. Our neurocheck intervals will remain the same. The scans, the antiplatelets, and anticoagulants held for 24 hours, as well as minimizing intervention. So really the only thing that's changing with our stroke care will be the medication that's administered within our health system. So if you have any questions about this information that's been presented, please email any of us on this list. We're happy to take questions and concerns moving forward. And if there's any issues that you come up after February 1st, please email me that we can address at Medication Safety Committee. Good enough? Great.